inflammatory substances, we have fatty acids, and we have hormones that are poured directly into the portal circulation, affecting the liver. Many of the fat hormones are still in the region of investigation. So, but the fat hormones are leptin, which acts centrally on the arcuate nucleus, and that will improve the food, decrease the food intake and increase energy expenditure. And we have the adiponectin, which is pro-insulin, increases insulin sensitivity, decreasing glucose uptake, decreasing gluconeogenesis. And we have the resistin, which is anti-insulin and pro-inflammatory. So regarding the truncal fat, which is exposed to high temperature and high pressure, these two lead to inflammation of the fat cell, hypertrophy of the fat cell that will recruit through secretion of chemokines that will recruit macrophages. Eventually, there are inflammatory cytokines. Among them is tumor necrosis factor alpha, interleukin 6, interleukin 1b, and C-reactive protein. And there is what we call adipocytokine dysregulation. Means that we have good adipocytokines and bad adipocytokines. Then with this, or in this case, we have increase in the anti-insulin pro-inflammatory cytokines on the expense of the good ones. Recently, it had been discovered that, actually before that, we have to know that our body contains 10 trillion cells. 90%, they are not belong to us. They do not belong to us. They are bacteria on and in our bodies. And in the GIT, we have a lot of these bacteria that are least in the esophagus and maximum in the colon. Among these bacteria, we have seven tribes with two main tribes, which are the firmicutes, which are bad tribes, pro-inflammatory and obesogenic, and we have the bacteroidetes, which are the reverse. So in obesity, there is association of two things. Number one is dysbiosis, mean increase in the bad bacteria on the expense of the good bacteria. And number two, we have less diversity. Most of the bacteria are the bad on the expense of the other tribes, the 7 tribes I mentioned. So the role of intestinal bacteria or intestinal or gut microbiome in obesity is that they break the food and leading to absorption or harvesting of more energy from the available food. This is number one. Number two, there is, as we all know, an intestinal barrier. This intestinal barrier is disturbed either by the type of food, the Western type of food, or by inflammation. So in this case, the lipopolysaccharides migrate into the circulation, into the body, and create a low-grade inflammation, similar to that caused by the fat. And it looks like what we studied before, and we said this is gram-negative endotoxemia. It's some sort of that, but it's a low-grade inflammation. Also through an effect, direct effect on the cells, the L cells in the distal gut, or by the help of bile acids, these can stimulate or modulate the production of gut peptides. And finally, there is a breaking down of the fat and release of fatty acids in the circulation that will modulate the fatty composition of the body. I know that these are medical knowledge, but these are the backgrounds of the operations that we have. Recently also, it has been observed that the bile acids, they have a very good role in lipid and glucose homeostasis. This is number one. And number two, they regulate also energy expenditure. This is something that came very new. And whenever we divert this bile, regardless the type of surgery, then we have improvement of glucose and lipid metabolism. So it can be assumed that surgery, through its effect on the bile, that this will lead to improvement of lipid and glucose metabolism. Going to the, if you look at this enterohepatic hepatic circulation, actually there is an interaction between the bile acids and the bacterial flora, where bile acid exerts some sort of toxic effect or static effect or whatever you can say on the bacteria. And on the other hand, we have the effect of bacteria on the bile acids. Bile acids, we have primary bile acids, which are cholic and desoxycholic acids. Through the effect of bacteria, they transfer this into secondary bile acids, which are lysocholic acids and desoxycholic acids. These secondary bile acids go into the portal circulation. They act on triglycerides and increase the pool of the primary bile acids, which exerts good effect after the surgery. Okay, we have finished now the medical part of the lecture. Now I'll go to the surgical part. The objectives of bariatric surgery is to have a weight reduction, which should be sustained, not temporary, and to improve the quality of life through improvement of the morbidity and improve the quality of life, I mean, including the quality of eating, and to prevent the premature death, and of course, to be cost effective. Minding that any comorbidity like diabetes or hypertension or coronary or whatever, they have a very long standing, cost on the long run. So how do they do that? Every bariatric surgery has a restrictive rule. They all restrict the amount of food that the patient can take. And if you bypass the part of intestine, then you will have malabsorption. If you bypass the stomach, then you will have maldigestion. If you bypass the pylorus, then you may have dumping syndrome. That will limit the amount and the type of food as well. In addition, as I said, to manipulation of the neurohormonal mechanism of weight control through either diminution of the ghrelin from the stomach through removing part of it or bypassing the stomach. This will decrease the ghrelin hormone, or bypassing the foregut, as I said, we call it foregut theory, or delivering the food very quickly to the distal gut. Then we have a release of GLP-1 and PYY. This will have, the three will have improvement of the metabolic syndrome and support to the insulin. In addition to manipulations of the microbiome, minding you that the stomach is a filter that modify the bacteria that we ingest. But if you bypass the stomach, then whatever you eat will go directly to the intestine. So we have, in this way, we will have a change in the type of the microbiome that will favor improvement of the metabolic syndrome. In addition to manipulation of the bile acid in the way that I said, or the surgery can have combination or can have all of these factors together. Well, when the patient is indicated for surgery, I said before that we have the National Institutes of Health criteria. These institutes are not surgical. Most of them are medical. It's an agreement of the big institutes in America that they agreed that the patient that is amenable to surgery should have a BMI of 40 or 35 plus a comorbidity, a major comorbidity. And regarding the age, recently it's limited between 18 and 65, but below 18 and above 65 can be dealt with on condition. Every patient should be taken on its own merit. And there should be no endocrinal treatable cause. And the obesity should be long-standing with failure of conservative measures. And the patient should be psychologically available, stable, with psychological stability without addiction, any sort of addiction. And some surgeons, they say that if the patient is a smoker, he is an addict, he's not a good candidate for surgery. And eventually, the patient should be well informed, should be motivated, and should understand that this is a surgery that carries a risk. So these are the criteria of the NIH. So what determines the outcome of the surgery? Why surgeries, they don't have the same outcome. So younger patients, they give better results, of course. Males, they give better results. The higher degree of obesity give less outcome. And patients with particular metabolic or psycho-behavioral problems, they have also different outcome with individual risk factors like the coronary or like cardiac or pulmonary. And finally, if a patient is doing well on diet, but they do well on diet and then they go back. If a patient will do well on one of the weight reduction ways, then he will do well with the surgery. The history of surgery started in the 50s of the last century, where they started by malabsorptive procedures, where food was allowed to pass through a loop of ileum that's only 50 centimeters, which the outcome of which, yes, they used to lose weight, but with a bad metabolic effects and nutritional problems. Second, in 1966, the first gastric bypass started. And they used to cut the stomach transversely, leave only 150 cc's of the stomach, and then doing one anastomosis. This is partly restrictive and partly malabsorptive. And the first restrictive procedure started in 1971 by dividing the stomach into two parts, first transversely and then longitudinally, and vertical banded gastroplasty remained until almost 2009. In 1979, Scopinaro came with his drastic procedure, giving the patient more amount of food, almost capacity of 300, but we have here, if you can see, this is what we call the alimentary, that is carrying the food. And this limb is, we call it the biliary, that carries the pancreatic and bile. And eventually, at the end, we have this common limb, which was only 50 centimeters. And that's why this had also a bad outcome regarding the nutritional state. So they improved that by doing the duodenal switch. This duodenal switch made the anastomosis after the pylorus. So in this case, we don't have dumping. And they elongated the intestine so to improve the nutritional state or minimize less. Yes. Professor Serag asked to show the previous picture. If you look at that, this is the stomach, the capacity of which is almost 300. And then food passes undigested over almost 150 centimeters. And then the bile comes. So the food is allowed to mix with the digestive enzymes only for 50 centimeters. That's why the nutritional problems was too much. In this case, they improved to some extent, making the common limb 100 centimeter, which is still low, but it was better than the biliopancreatic diversion. In addition, the anastomosis was not made with the stomach, it was made with the duodenum. But in this case, this is a very difficult technically. So with the advent of the laparoscope, the Roux-en-Y gastric bypass started to be a laparoscopic procedure. And in this case, you can see that this is the alimentary limb and this is the biliary limb. And this is the common limb. And in 2005, Phoebe added a very stupid idea. He put a ring in this area to minimize the food intake, which is, from my point of view, is something stupid. And there are controversies regarding the pouch of the stomach. It's 50 or 30 or even 10 milliliters. And the way of anastomosis, we call it the gastrostomy, by circular, stapler, or linear, or Hansoon. It's anterior to the stomach, something. I mean, there are many controversies. Also, the length of the alimentary limb and the length of the biliary limb. And recently, now, the most recent technique adopted by most of the surgeons is to have a biliary limb of 100 centimeters, because they said that this has effect more than the alimentary limb, and an alimentary limb of also 100 or 120 centimeters. So this is the most accepted way right now. Recently, also, another form of gastric bypass was introduced, where they made a long stomach, long cylindrical stomach, with only one anastomosis. And they call it, at first, a mini bypass. And mini was a vague name, which actually, it was not a mini at all. It was mini for the surgeon, but on the patient, it was more malabsorptive. And it was, at the start, this limb was 200 centimeters. And then they found that 200 centimeters for the bile with bacterial overgrowth. Then they said, no, probably 150 is better. But still, this is an experimental, and this surgery is not accepted absolutely in the USA. The band was introduced in 1986. At first, it was not adjustable, and then it became adjustable. It was quite common until 2011, and at this time, it is actually being withdrawn from the market. Gastric pacing and implantation of an electrode was tried in the stomach, but I don't think it was a very successful thing. Now, going to the precursors to the idea, how did sleeve gastrectomy, which is the most common surgery being done now, there was two precursors. Number one, cutting the stomach longitudinally in biliopancreatic diversion on the right side, and on the left side, a surgery presented by Johnston. He made a very long gastroplasty without a band, and he claimed that it gave good results. And then came the sleeve gastrectomy, the very famous and the very common surgery being done now. That is the sleeve gastrectomy, where the stomach is being cut longitudinally this way and removing the rest of the stomach. This is the only common surgery now that is irreversible. And there were, because it was not, the outcome was not very high, so many modifications were added to it, like ileum interposition, taking part of the ileum, distal ileum, up, or anastomosing the duodenum with the distal ileum. Also, in fact, sleeve gastrectomy is an easy operation, and it's common not because it's the best, but because it is easy. And there are some circumstances that gastric bypass or any other surgery is quite difficult. So in super obese, in males who have a bulky liver or bulky omentum, in extremes of age above 60 or young patients, in patients who have adhesions with the small intestine, or in patients that cannot withstand a long surgery because of American surgery of anesthesia high ranking. So in such cases, sleeve gastrectomy is a good option. So it entails the removal of between 75 to 85 of the stomach. So I said it's irreversible. But because this surgery depends too much on the behavior of the patient, then modifications came. First, the plication was introduced actually by the Iranian people, where the staplers were not available. And up till now, this plication is an experimental surgery, although it had been done for more than 12 years. But up till now, it's not accepted by the rest of the world. And many modifications were added to the sleeve, anastomosing with the proximal jejunum, with the distal ileum, and because of anastomosis with the duodenum carries a high risk, then another idea came, that is the SASI that you will hear too much nowadays. SASI means anastomosing the pylorus with the distal ileum, maybe something like 250 centimeters or 300 centimeters from the ileocecal junction. It means that food will pass through the pylorus, and part of the food will pass directly to the distal ileum. So it means that the GLP-1 and PYY will rise quite more densely than with the classic sleeve gastrectomy. Up till now, this is an investigational surgery that is not approved 100%. Endoscopic techniques, everybody is aware. I mean, you particularly are aware more than I do. BIB, Botox, endoluminal sleeve, pose, etc., etc. These have a very good role, but not in morbidly obese patients. I mean, not in patients above 40 or more. Now, regarding the number of bariatric surgeries, according to the IFSU, that's International Federation of Surgery of Obesity, that more than 600,000 surgeries are being done in year 2016. And if you go to this registry of American registry, you can see that starting 2011 until 2018, the number of surgeries is almost doubled, and the amount of sleeve from 17% to 61%. The gastric bypass dropped almost to less than half. The abdominal, the band, the adjustable gastric band dropped from 35 to only 1% in 2018. And something that deserves to mention, that the revisional surgery had risen from 6 to 15 plus, means more than double, because more surgeries are being done, more failures, and more redo surgeries. And you will notice that the balloon has now a place in the management of obesity, and up to 2% of the obese patients are being treated by the balloon. Well, now it's obvious that for morbidly obese patients, that surgery is the best option. Which type of surgery? Mine, of course. It's not mine. I don't mean my particular, I mean personal. No, but every surgeon thinks that his surgery, the one that he likes, is the best, which actually is not true. This is not true at all. But in general, bariatric surgery do better, and gastric bypass can have a better result. We have 3 standard surgeries: the gastric bypass, the sleeve, and the balloon. I mean, not the balloon, I'm sorry, the adjustable gastric band. So gastric bypass gives better outcome than the other 2 both in weight reduction, this is the long term after 6 years, and also in control of diabetes, improvement of the hemoglobin A1C. And in treating the comorbidities, there is here improvement and cure, and I object on the term cure because there is no cure in these comorbidities. There is nothing called cure for diabetes, but there is a long remission for management of diabetes or hypertension or whatever. But there is a definite improvement in these comorbidities. And according to the International Diabetic Federation, that it's documented or now approved that patients with diabetes above 35 are amenable to surgery. Not only that, patients between 30 and 35, if they have a bad control otherwise, bad control by the medical ways, or especially when they have another risk factor like hypertension, dyslipidemia, or history of heart attack, they are amenable to bariatric surgery. This is the view of the International Diabetic Federation, not mine. And in fact, there is a marked improvement in the mortality of patients, of obese patients. This study by Adams is a very famous study that he showed that 40% improvement after bariatric surgery compared to non-operated patients. And if you look at here, for diabetics, the improvement in the mortality due to diabetes was 92%. Many other studies followed, and the improvement ranged from 29 to 89% in the mortality after bariatric surgery. So it's useful, really. But on there is a dark side of bariatric surgery. There is some patients, they cannot be completed laparoscopically, and they need to be converted into an open procedure. We have other complications like bleeding, leaks, injury, ulceration, obstruction, thromboembolic events, reflux, ischemia in something in the intestine or in the stomach, and bad psychological or nutritional effects. And we have failure. Failure means, from the surgical perspective, inability to lose more than 50% of the excess body weight. If you lose more, then surgically you are successful. Why? Because if you lose more than 50% of the excess weight, your comorbidities drop down markedly. And if you fail to improve the comorbidities, then your surgery is not successful. If the patient is coming to treat his diabetes, to go into remission, and you fail to do that, then you failed to benefit the patient. If the patient has a bad quality of life, like losing too much weight, inability to move, or vomiting all the time, bad quality of eating, then your surgery is not successful. There are scoring systems that gives a score from 1 to 9 to show that this surgery is successful or not. Well, this is a very important slide that everybody should know especially the surgeons, that sometimes these surgeries fail. Why sometimes our surgeries fail? Number one, the type of surgery. If you select the wrong type of surgery or do the surgery for the wrong patient, then you will not do good. If you do the surgery but not in the proper way, then you're not doing good. And if you do your job perfectly, but the reaction of the body, the response of the body is variable. We are not a single, we don't have a single physiology. We don't have a single reaction. There is nothing that you can say it can fit every patient. This is not true. So dilatation happens after sleeve gastrectomy. Some patients, they develop double or 3 times the size of the stomach that was operated. And the tolerance of food. Some patients, they have, for example, after bypass, they have dumping they cannot tolerate sugars. After some time, they do tolerate. Sometimes patients tolerate a big amount of food that was not supposed to do. Also, the gut motility, whether the motility of the stomach after sleep. Some patients, they get hungry every 1 hour because very rapid evacuation of the stomach. This is something personal. On the other side, in the gastric bypass, sometimes the intestinal motility is very slow. With the development of, as we know, we have many types of intestinal motility, the propagative type, and we have segmental type, and we have the reversal type. So the propagative type decreases on the expense, decreases for the sake of the other types, where food stays too much in the intestine. So more absorption. And some of these patients, they have, on the contrary, they have constipation. Although some of them, they have diarrhea. So it's something variable. After the surgery, after the sleeve gastrectomy, the ghrelin should drop, but it can, regain after some time. Or GLP-1 after bypass gets high, but after some time it drops down. Energy expenditure is variable in response to bariatric surgery, is variable among people. It's not the same. Complications like gastrogastric fistula can allow patients after gastric bypass to eat much more. Also, some psychological or environmental factors can happen to patients after the surgery, where they lose the motivation, they gain much weight. So eventually we have what we call the honeymoon of the surgery. The honeymoon is the period of 1.5 to 2 years that follows the surgery. Afterwards, many patients, they fail or they regain some of the weight or too much of the weight lost. We have also risk of deficiencies of protein, calcium, iron, macro and micronutrients, ferritin, albumin. Many patients go into anemia and their life is bad. B12, thiamine deficiency. We know Wernicke-Korsakoff syndrome, that's very well known after the surgery. We have folate, vitamin A, E, D, zinc deficiency, and we have the refractory hypoglycemia. This is a very serious complication after especially the gastric bypass, where there is increase in what we call acute insulin response, or high activity of the beta cell population, or beta cell, it functions more than normal, where the food is not, the blood sugar is not the same. So these people, they fall down or they lose consciousness, and some of them, they die. Also, we have vitamin C deficiency, selenium, and copper deficiency. Psychological problems are there, complications. So patients may go for, in depression, suicidal attempts, addiction for alcohol or other drugs, or they may change their eating habits into night eating or binge eating to compensate for the deficiency if they are not prepared or if they are not evaluated properly before the surgery. Surgeons say that our complications, mortality rate is not high. This is true. Compared to craniotomy, which has 10%, or esephegectomy, pancreatectomy, cabbage or whatever, or even hip replacement. But these surgeries are indispensable. But our surgery has, other alternative, that is the diet or whatever. But in general, the mortality of bariatric surgery is not that high. In conclusion, obesity is a worldwide epidemic, and surgery gives the best outcome for morbidly obese patients. This is important, morbidly obese patient. The surgery means a dramatic change, a big change in the anatomy and in the physiology, or both of them, anatomy or the physiology or both of them. And there are complications being a surgery. There are complications, and there are adaptations. There are failures. So, what is the proper way? The proper way is to have a multidisciplinary approach or multidisciplinary team. This team should include the physician, should include the endoscopist. By the way, endoscopy has a very important role either before surgery, evaluating the patient, or after surgery, correcting our mistakes or our complications, and psychological assessment before and after, the nutritionist, the physiotherapist, in addition to the surgery. So what I can say at the end is that multidisciplinary team is a necessity for good outcome. Thank you.
Thank you, Professor Fahim, for this very illustrative presentation. And really, we aimed at this. We aimed to hear from you what you have said, and this is achievement. The most important point is a multidisciplinary approach you pointed at, which is very important. It is not a challenge. It is not mine, as you said. It is our problem to solve. Yes. Yeah. We have with us, I saw Professor Ayman Salah, Professor Hisham Abdel-Daim, and Professor Ahmed Abdel-Aziz, and Professor Hani Shahab. They are moderators. So, Hani, you deal with them.
Thank you, Professor Fahim. Thank you for our esteemed surgeon joining us today. It's always nice to have an explanation to us physicians of what is going on in these surgeries, because we're seeing these patients all the time in our clinics. I have a question, and I think it could be open to all of you. You mentioned that the age, there's a limit for the age of 18, but I've seen patients, and we know that now it is being performed also for adolescents and even children. So can you tell us when is it suitable for a child to have a bariatric surgery? Because sometimes we have these patients in our clinics with their parents, and they are pushing for a bariatric surgery at the age of maybe 13, 14, and we're used to just telling them, no, don't do it. So is this correct or not, Dr. Fahim?
Actually, this is absolutely correct. I operated on patients with 10 or 11. They were referred from a neurosurgeon because they have increased intracranial tension caused by the obesity, and they had almost papilledema and about to lose their eyes. This is one of the cases. I operated on patients, young adolescents with hypertension because of the obesity, or diabetes that's not juvenile, type 2 diabetes because of the obesity. Of course, the diabetes that I mentioned in the lecture, it was type 2, of course, not type 1. So in some instances, you have to operate on adolescents. By the way, pediatric surgeons, they said that operating on adolescents improve the growth curve of the patient. So they recommended operating on adolescents, but we have to select the patient. Number one, they have to be morbidly obese. I mean, BMI should be high, and there should be some sort of a risk that you will prevent, and there should be a participation, a good participation by the family, family support. And they said that it is better for the adolescent patient to have the maturity, psychological maturity and physical maturity. So in pediatrics, I mean American, they said that it's the age of 13 for the female or 15 for the male. But still, below this age, in some circumstances, you can operate. So eventually, the surgery is available not only in adolescence but also after. But every case should be taken on its own merit. I mean, it's not just the patient is plumb that you will take every child, every plumb child to be operated upon, because definitely there is an effect on the growth. According to the pediatric surgeons, they say the growth curve is improving, but what about the nutritional state? What about the psychology? Should this child accept to change the dramatic change in his life? They like to eat. So if you just withdraw this benefit from them, some of them, they go into psychological depression. So, I mean, every patient should be taken carefully if he is below 18 or if he is above 65 as well.
Thank you. Hello, sir.
I would like to have
you don't have to have a comment. Yes.
I have a comment, please. For
yes, Dr. Amr, please go ahead.
it's يعني طبعا I know Dr. Fahim, he is one of the best in bariatric surgery, but there are a lot of untrained surgeons now doing bariatric surgery, and on TV there is a lot of advertisement and strange people doing bariatric surgery, and we saw a lot of complications and a lot of mortalities. And I assisted Karim Abul Magdy in many complications after bariatric surgery, and it's a fatal complications. And أنا ماسك الفورنسيك part for bariatric surgeon في وزارة الصحة, و many disasters because residents and young people doing this surgery, and it's not easy surgery. It's sometimes it is a catastrophic surgery. There should be a license or a regulation or anything to tell who is doing this surgery and who will not do this one. But I think we are waiting for a medicine and to replace this type of surgery, and it's coming soon. I think just one tablet, one thing, something like that. And I think by bariatric surgery, we add one cause of mortality for surgery, one cause of morbidity. And I hope there's something to something like medicine, something like something more easy for a patient to reduce their weight. I don't know, Karim Abul Magdy is here or no?
I think he should be joining us, but he's stuck in one of his very long surgeries. So I think he has a problem in joining now.
He's talk about reconstructive gut surgery. He will talk about how about gastroplasty and how to manage the complications of leakage after after bariatric surgery. And I assisted him in more than 50 cases for complications of bariatric surgery, and the surgery will last for more than 15 hours or 20 hours. So I wish he will be here to talk about this.
I'll call him tonight when he finishes the surgery. We may move his lecture tomorrow. I will manage with the organizer to find half an hour anyway.
Yeah.
Tomorrow I'll declare it.
Yeah, because yesterday he told me that it's on Friday, not Thursday. I tried to tell him it's Thursday. He told me that the organizer told him it's Friday. So maybe
Thursday is his Friday or the reverse. Look, Dr. Ayman, actually, when we talk about bariatric surgery, we should not, link this with the wrong practice. When we say bariatric surgery, we mean the bariatric surgery that's conducted in a proper way. What you are saying is absolutely correct. I agree totally with you in the situation of our country. But why particularly the bariatric surgery? Look to others. Look to cholecystectomy, look to hemorrhoidectomy, look to every practice. It's the problem of the practice itself, of the system. It's not, everyone is allowed to do whatever he wants. So this is not the problem of bariatric surgery. This is the problem of the surgeons or the system that allows untrained surgeons to operate. That's different. باي ذا واي دي فضيحه طبعا على الخواجات، في خواجات سامعيننا دي فضيحه يعني.
هم عندهم كده برضو واكتر،
بس
يعني في امريكا برضو في كده برضو.
ما عندهمش الشكل ده، ما عندهمش الدنيا سداح مداح يعني. بس ده مش ذنب مش ذنب الجراحه نفسها، ده ذنب السيستم اللي بيسمح لواحد مش متدرب انه يشتغل. معلش اتكلم بالعربي عشان يسمح لواحد مش متدرب انه يشتغل اللي هو عايزه، وانه يسمح لحد زلنطحي انه يطلع في التلفزيون ويقول انا بطل العالم، يوم الناس تجي له بالزوفه. لا، ده مش غلطه الباريتك سيرجي. ولما انا باجي اتكلم، انا بتكلم على الباريتك سيرجي، ما بتكلمش على الباريتك سيرجن او السيرجنز. انا قلت حاجه واحده بس مضحكه، انه لما تيجي تسال اي واحد يقول لك انا عمليتي احسن عمليه. وعلى فكره الخواجات هم اللي بيقولوا كده. يعني تسال الراجل بتاع الميني جاس باي باس يقول لك انا مره سالت الخواجه راتلج ده بتاع العامل باي باس. I asked one time I asked حد يقول لي كويس بالعربي. I asked Rutledge at one time. I told him that there is no ideal surgery, because I do believe there's no ideal bariatric surgery. He said, no, sir, my surgery is the ideal one. طبعا this is crazy. يعني his surgery is one of the worst, by the way. يعني يعني everyone is considering that he is doing something very good. And if you notice, even in the presentations, in the congresses, that one is presenting his work and everybody is saying that this is a piece of shit, and he is presenting it as a piece of art. يعني, by the way, surgeons are crazy. They overestimate their abilities and their work. And this was proved experimentally, that surgeons, they always overestimate their power or their what they are doing, I mean, or their efficiency. طبعا I mean most of surgeons do that. There are يعني reasonable surgeons, I mean, but there are among these are those who present their work, get one patient who lost weight on TV and say, you see, but he doesn't show the patient that he died. He doesn't show the patient that he didn't lose enough weight or complicated. And there are a lot of complications. Yes, there are a lot in our country probably. عندنا يمكن هيبقى نسبة المضاعفات أعلى من بقية العالم. يمكن. ليه؟ لأنه احنا بنسمح بناس تشتغل، الناس غير مؤهلة. ده مش ذنب الجراحة، ده ذنبنا احنا، ده ذنب الجراحين، ده ذنب النظام. العيب في النظام يا برايز.
الحقيقه انا عندي كسؤال مننا احنا، ان احنا بنشوف عيانين بيجوا لنا في الاول عندنا يسالونا على حاجات للتخسيس وكده، وبعد كده انا من الناس اللي مؤيده جدا للبارياتريك سيرجري والباي باس في الناس اللي هم اكشلي موربيدي اوبيز يعني. لكن كل العيانين عندهم a very bad idea عن كلمه باي باس. اول ما تقول له كلمه باي باس يقول لك لا انا هقعد ارجع طول حياتي وهموت وهيجي لي نقص فيتامينات وبتاع. فانا اعتقد ده جاي من الجراحات القديمه.
احنا بص الباي باس يعني is technically more demanding than the sleeve. The sleeve is common not because it is the best, not because it is even good. It's common because it's easy. And the promoters of the sleeve are the surgeons themselves, the surgeons and the industry. And the bariatric surgery, part of it, I mean, part of the promotion is directed by the industry, by the companies. They want to sell more. And the surgeons, they earn more. This is true. But in fact, bariatric surgery in its proper place is quite useful. In its proper performance is quite useful. And the complications should not be more than the international rate of complications. But the problem is that whenever you select a wrong patient, or whenever you do the wrong surgery, or you are not trained for that, By the way, not only in this, but as I said, not only يعني مش مشكله في البرياتريك سيرجري، في اي حاجه ثانيه. ما هو اللي ما بيعرفش يشتغل ليفر وهيشتغل ليفر هيموت عيانين، واللي ما بيعرفش يشتغل مراره ويشتغل مراره هيموت عيانين، واللي ما بيعرفش يعمل كونكتيف وبيعمل يعني الكلام كده. بس البرياتريك سيرجري يعني كومن لانها يعني فروتفول، لانها يعني في النهايه يعني سبوبه كويسه للجراح وللشركه والكل اللي شغالين في المنظومه والمستشفى واي حته يعني واصحاب. ده صحيح يعني، لا يعني مش كلهم بقى.
سؤال من الدكتوره شيرين بروفيسور اوف انترنال ميديسن في عين شمس.
Assalamu alaikum. Thank you for your lecture. It was perfect. I just want to ask, in cases of gastric sleeve, there any procedures to be done like suturing or applying clips together with the stapler to decrease the incidence of hematoma after the surgery? I saw this or heard about this from one patient. Another question, what about the iron deficiency anemia, the percentage? How many patients do get, because I had a patient with iron deficiency anemia resistant hemoglobin 8.5 and not improving only على intravenous iron. And also the intrinsic factor for the absorption of vitamin B12. Is it removed with the removal of the fundus of the stomach, and that's why the patient must receive intramuscular vitamin B12 injection?
Thank you for the two questions. One of them is a pure surgical question, which is, do we reinforce the staple line? The reinforcement either by some materials or by sutures. This has two aims. Number one, it's supposed to decrease leakage, and number two, it's supposed to decrease bleeding from the staple line. It's a long staple line, and the tension inside the stomach is high because the pylorus is tough. I mean, is a strong sphincter, and it does not allow the passage of food unless it is emulsion. So the contraction of the stomach and the resistance of the pylorus create a high pressure area. So if the staples are not firm enough, are not, very good, are not tough, then leakage can happen. And I do believe that in the proper practice, the rate of leakage of sleeve gastrectomy is more than the rate of leakage in gastric bypass, by the way, because gastric bypass is a low pressure surgery, but sleeve is not. So some surgeons, they like to invaginate or like to reinforce, and some of them, they claim this improves, and others say no, this has no effect, or the rate of leakage and bleeding is almost the same. I'm talking about the suture. But reinforcement of using some material to reinforce the staple line decreases the bleeding, but it does not decrease the leakage, because most of the leakage is because of ischemia. That has nothing to do with this step. The second question is the deficiencies. Look, if you remove the biggest bulk of the stomach, 80% of the stomach, it has a job, and it has the acid itself. I mean, the amount of acid and the intrinsic factor drops. So our observation is that we have a lot of iron, vitamin D, calcium deficiencies after the sleep. We have also zinc deficiency. That's, I'm not sure of the relation to the sleep itself, but the stomach is important for the absorption of iron, for the absorption of calcium, and probably vitamin D. I'm sure vitamin D it has an influence on that. Right. So reasonably, if you remove most of the stomach, so the function of this part should be affected. That's natural. But the problem is that you mentioned a refractory resistant cases. Yes, this is true. And this is what I said adaptation. Some patients, they don't have deficiency at all. And some patients, they have severe deficiency. It's personal. It's a code. Code belongs to the patient. It is the adaptation of the patient. Some of these patients, after 1 year, they have no problem at all. And we do the tests. They are all perfect. Some of them, they remain, and they need to have intravenous iron or even blood transfusion. So the response of the patient to any type of surgery, that is totally personal. But when we say the outcome of a surgery, we don't mention or we don't mean every single patient. We say the mean, the biggest bulk of the patient, the average. But in this average, one of them is going right and one of them is going too much left. But we mention the average, the statistical number, not every single patient. And this what we say to the patients. Ethically and originally, every patient undergoing any bariatric surgery should receive a lifelong nutritional support, at least evaluation, at least tests every now and then. Reasonably, this patient is not eating enough amount. If you eat 1 kilogram, you have 100 grams, say, of vitamins. So if your meal is 100 grams, then you have only 10 grams of vitamins. It means you should be deficient. So, but people have a very big diversity in this tolerance. So it is the follow-up, nutritional follow-up. This is what we say. If there is something deficient, then you should repeat. That's it.
To give proton pump inhibitor before after surgery, lifelong.
You are talking about sleeve or gastric bypass? No, for gastric bypass, because the pouch size is quite small. So we give proton pump only for 2 months. Regarding the sleeve surgery is a refluxogenic type of surgery. And I do follow up virtual gastroscopy and volumetry for almost all my patients. And I can say all the patients, they have, after 1 year, they have some degree of hiatal hernia. Migration of the stomach into the mediastinum. This should happen because you have disturbed all the mechanisms, all the physiology that prevents the reflux or migration of the stomach into up. And the stomach and the esophagus are one line. Down is in the abdomen is high pressure. In the thorax, it's a negative pressure. So reasonably, without the support, this should migrate up. If it did not migrate, then physiology is not true. I mean, what we studied was not correct. So what I observed in my practice and over a long period is that almost every patient whom I did volumetry or virtual gastroscopy after the surgery, 1 year or 6 months, there is some degree of hiatal hernia. And some of them, they don't have reflux or they do not complain actually of reflux. And some of them, their life is too bad. They are not too much, but I have patients. I have patients that I transformed into gastric bypass because they have a bad reflux and they suffocate during sleep.
Thank you very much, Professor Fahim. It was very informative, and I think we have many more questions. I think for the time, we'll have to conclude. Thank you for our fellow surgeons for being with us today. Professor Serag.
Again, we thank you, Professor Fahim. We really enjoyed, and we need more time, the more and more to talk and to understand more. And we always, and we notice that some patients benefit from only diet, some patients benefit from leave, some patients benefit from a bypass, but probably the choice of patient for treatment which will guide, so the proper choice will guide successful result. So this needs senior professor to guide things. Well, we reached the end of the first day of our annual conference, started 9 in the morning. It was very fruitful and successful. We started from Wuhan in China, and we end in Cairo. And tomorrow at 10 o'clock, we will start by esophagitis, Dr. Shirin. We thank you very much. And probably, my friends, Karim Abul Baghdadi will be 8:30 tomorrow by night, inshallah. Okay, thank you very much, and assalamu alaikum.